Hey everybody, it's Rich Hazel. I'm in Buffalo, and we've got our special guest here, Josh Margolis. Dan Dominguez isn't able to be with us today, and if we arranged a time for all three of us, I think we would be doing this after Josh's webinar that's coming up mid-March. So we're just decided to do this on the fly, really quick, put it together really quickly. I thought it was important for us to do this because I've been seeing a lot of posts in a couple different groups, the Motor Point group and Jamie's group, the DAO group, about spinal segmental treatments. So I thought this was a perfect time for us to let Josh kind of fill in the gaps of knowledge that our profession has about where it all came from and some of the reasons why we should all be interested in learning more about them. So, Josh, I'm going to pitch to you. I'm personally familiar with gun. I'm not that familiar with man, and I'm familiar with some of the stuff that came out of McMaster via Alejandro and probably originally from Craig Pence, I'm guessing. So can you give us a little, actually, if you want to introduce yourself, because I forget, not everybody knows who you are, and I feel like we all know who you are, but
Yeah.
there are probably some new people who don't. So if you don't mind, just give a little background, explain how you came to where you are. I know you've been in practice as an acupuncturist for decades. So
Yeah.
so let us know what's going on.
Yeah. So I'm Josh Margolis. I'm in Santa Rosa, California. I've been practicing since 2001. I just had my 20th anniversary earlier this month. And I have had the good fortune of, along my journey, of getting some really key mentors, and one of whom was Brian Bouch, who's a physician in Petaluma, just about 20 minutes south of where I'm at, who was an earlier practitioner of acupuncture, and he was an instructor and preceptor in the Helms Medical Acupuncture Program. And in working in his office, part of it was he mentored me in medical acupuncture. So that's what really kind of opened my eyes. I had already been exploring the works of Si Chan Gun and Joe Wong, which I think was helpful in my job interview when I tried to get that job back then. But you know, he took me a lot further and really opened up my eyes in terms of what was possible in an anatomical and from taking an anatomical approach to acupuncture. At the time, nobody was really talking about that. I think Fred Lerner had a program with some stuff going on, and Whitfield Reeves was around, but other than that, there really wasn't that much. It wasn't as rich of a field as it is today. So we owe a lot of these people, you know, a great debt of gratitude who came before us, who started laying out these ideas that we're going to discuss in a little bit. So Rich already mentioned Chan Gun being a Canadian pain management doctor. And he had this concept of basically segmental hypersensitivity. So from nerve depression, denervation's hypersensitivity. And so what he did was kind of he developed a treatment methodology. He was very against acupuncture at first in terms of being associated with it, but it was based on the concept that he would treat the motor points. We kind of owe him a huge debt of gratitude, but he would treat motor points and trigger points and the segment that the muscle came from. And so he would, like, you know, for a lateral epicondylitis, he would treat, you know, all the muscles that attach to the lateral epicondyle, and then he'd be looking, okay, that's radial nerve. And so he would treat derivatives of the radial nerve, and he would treat segmentally it up at the neck. So he would be treating, you know, C5, 6, 7, something like that. to try to help that. And so that was a really kind of key innovation. I mean, on a very simplified level, it's kind of taking Travell's work and then just adding the spinal segment back into it. So, if and I'll talk in a moment just kind of why that's relevant, but that's a really important thing to concept to understand, is that if there's injury or positive input like acupuncture, it will affect all the structures that share the same embryological segmental origin. So that's dermatome, myotome, and sclerotome. Those are, branches of the paraxial mesoderm in the embryologic development. It's a particular stage, right when folding is starting. And these cells kind of migrate out into 3 different layers, and the different, there are different derivatives from each of those. And so that's where dermatome, myotome, and sclerotome come from. Dermatome being the tissue directly under your skin, so like the dermis in that layer. The myotome being all the muscles, and sclerotome being bones and ligaments and some tendons. Now, all the layers can make all the different structures. It's not like a hard, fast thing. There are some funny little derivatives that don't follow that rule exactly, but that's where the segmentation starts, pretty early in our development, and it continues through life. Yeah.
And that specificity, is that something that Felix Mann was developed, like really getting into? Is that where you learned more about the sclerotomes and the osteopecking and things like that?
Yeah, Mann definitely was aware of that. For those of you who don't know who Felix Mann was, he was, one of the early English language acupuncturists. He was practicing in London I want to say he started in the 50s maybe. And, he had studied in Germany, and in the rest of Europe, there was a little more acupuncture going on at that time. And, he was very traditionalist. I mean, he taught himself Chinese and went to China and learned, more there. And then at some point, he's kind of decided that there was no such thing as acupuncture points, and that everything was about regional stimulation. And so then he developed kind of 2 non-meridian acupuncture styles or methodologies that have been taken up very much by the British acupuncturists and medical acupuncturists. So that'd be periosteal and superficial acupuncture. So they do like, they just subcutaneously, very light stimulation. So you kind of have that range from really intense stimulation to really light stimulation. And they were doing, they've been doing stuff in the hospitals and all kinds of interesting settings using these kinds of methodologies. If you're interested in some of that history, his books are great. I like Reinventing Acupuncture. His early books he kind of disavowed later, which were the ones that really had like all the concepts of like qi and blood and yin and yang and all that stuff. He just sort of like eventually just said like, yeah, the kind of the area around spleen 6 is good for lower abdominal problems, gynecologic problems, blah, blah, blah. And, you can tap the bone or you can do superficial needling. They both might work. And he has these funny illustrations of people with needles sticking out of like all over their bodies with big old grins.
But didn't Dr. Wong also pretty much say that anything can be an acupuncture point? Didn't he say, you could move your points to closer to the nerve, and maybe it'll take 2,000 years before everyone agrees that that's a point, but you can have positive effect on the muscle and the nerve, and pretty much everything can be a point.
Yeah, I mean, everywhere there's, some, as long as you can feel the needle in some way, I mean, which doesn't always have to verge into conscious threshold, it's as long as your brain and your spinal cord are aware of the needle, something will happen. So, yeah, but then there's going to be targets that have like higher concentrations of different kinds of nerve fibers or whatnot that will have a stronger central effect. And then there's, for some reason, and we're still sorting this out, like, stomach 36 stimulates like a little what do they call them? It's not a ganglia in the brain. It's a nucleus in the brain that's like right next to the vagus's nucleus. And so there's some sort of weird cross wiring that happens. And so that's why you get all these digestive effects, or, some researchers are positing why stomach 36 really does affect gut motility. They're starting to be able to look in the brain. We just don't understand all those interactions.
So it's balancing more autonomic nervous system, parasympathetic dominance from stomach 36, more like getting more of a parasympathetic input to help the motility.
Yeah, I mean, stomach 36 supposed to increase, bowel motility, so some kind of parasympathetic effect. So it is affecting the vagus nerve somehow, but it's not like clear wiring, as in like when we're doing like a lot of musculoskeletal pain stuff that we're working with, where you're like, okay,
Yeah.
so the quads are in trouble, you just run it back. Quads are in trouble, femoral nerve, L2, 3, 4, right? So if you can do that, it sounds, I'm just rolling it off my tongue. I can do it for a lot of places, and some places I have to go and look up it and still look it up. It's a lot to hold in your noggin for a daily piece. But if you know the general zones, like hip flexors are L2 to L4, hip extensors are pretty much L4, L5, really L5 to S2. And you kind of, if like the main things, you can go back and treat at the spine very easily without, if you go a segment up or a segment down, it's not really that much of a problem. If you do too many below, it's not going to have as much effect, because there is a blocking effect in the gate theory. If you go above, you can actually block ascending messages. So if you miss above, you're actually still helping. That's one of the reasons large intestine 4 probably helps with all pain things, because it's above most pain in the body, right? It's a C6, 7, something like that. So then everything below that, it can affect all those things pretty strongly. So that's kind of thing. If you're just thinking segmentally, I mean, there's central nervous stuff happening, which we're not going to delve into. I'm a clinician, not a scientist. So I'm trying to figure out how I can use this information for me. Yeah.
And
so man didn't, he sort of hinted at it, but he didn't really get into like thinking totally sclerotomally. Where you really start to see that is like the osteopuncture work. I forget the guy who came up with that, but he was, he was a neurologist, and I remember the story. I can't spacing his name. Basically, he would take hypodermic needles and then stick them in the periosteum, hook a negative lead onto them, and then put the positive lead on the in a muscle of the same basically say segmental level. So if you had a problem in the hamstring, then he might do the PSIS, which depending on where you look at it on a sclerotome map is either S1 or S2. So then he can then put the positive in the positive lead in the hamstring. So then he's running at something at like 200 hertz, 250.
Wow.
I think he was doing originally, so high. And that idea being basically to kick up as much endorphin as possible. And those treatments are successful. It's hard. They're a little intense, but sometimes I find like for stubborn sclerotomal problems, like where you have like, by sclerotomal problems, I mean ligament injuries, meniscus injuries, joint problems that just aren't resolving by treating the nerves around there. So that's that. Yeah, Phil, no, osteopuncture is not from Upledger, although he probably was trained in it. Upledger was an acupuncturist as well, as an osteopath. A lot of the DOs, a lot of the manipulating DOs did study osteopathy, acupuncture, partially from Dan Bensky, whose name means a lot to us. He's a DO. So there's a lot of he was an acupuncturist before he became an osteopath. Yeah.
So Josh, what can you tell me a little bit more about the Helms Institute and where they are today and because what's fascinating to me is so many of your influences actually must have known each other at the Helms Institute. I don't think Felix Mann did, but wouldn't Gunn and Wong and Alejandro and what's the other one I was thinking? I don't know if Dr. Craig had anything to do with Helms Institute or if he was just, his material was being taught at the Helms Institute via, and I forget his name, someone else at Helms. Was it William Helms?
Joe Helms.
Joe Helms. So what I find interesting is I think that they successfully kept a lot of information from us as acupuncturists.
They wanted to.
And somehow it escaped their Loctite barrel. And now many of us have learned these things, but we learned it through somebody else who learned it from someone from Helms. Am I right?
It's like to some degree, yeah.
Some of us have learned these things, but we thought it was a certain specific acupuncturist, but that acupuncturist often learned it from someone from Helms.
Yeah, Helms is a storied character. He has admittedly really wanted LACs to crawl in a corner and die, I think were some of his words, according to my colleague. He's not a big fan of our profession and really wants physicians only to be practicing acupuncture. So that's like a first thing. So that's why it's pretty unusual for an LAC type to have had Helms type training. But yeah, he studied in France. France has had a long acupuncture tradition among physicians, and he studied in France. So like his influences are like Win Van Gie and Tran Viet Zong, and then I think Yves Requena and some of those people. I can't speak for his whole thought process, but that's kind of where that biopsychosocial type acupuncture, constitutional kind of thing. And then he really kind of made things into circuits and tried to make it a little more streamlined so that physicians could learn it. But at the same time, he was really interested in people who were doing scientific work. And the funny thing about all the names you mentioned, for all Canadians. So you have Gunn, he's in BC. You got Wong, who is in the Toronto, Hamilton area. You got you got Bill Craig, who's Canadian, who ultimately moved to the U.S. And you've got what was the last one we mentioned? Other than Felix Mann, he's British, but a lot of that was coming. Partially it's because there was that group.
Well,
you got Melzack and Wall were in Toronto, and you've got who did the gate control theory, and then you also had Bruce Pomerantz, who was in there. Bruce Pomerantz did all the early electrical acupuncture research. His lab was like huge in like all of our information that we have, early information on how acupuncture and endorphins and all this kind of stuff. All this stuff was happening in Canada. So I think, you see a lot of this stuff kind of migrating south. Alejandro Loriaga is also in that area. So
not far from me, actually. In Hamilton, in McMaster.
Yeah. So all that stuff really, I think that was just a rich kind of bed for, I think that, Canadian physicians who I think were involved a little bit more. And that might have been, I don't know the history of that. Maybe it's because of the French and English. Canada has a little more transparent relationships with those countries. So, ideas going back and forth.
But there was this moment in time in the mid 20th century where so many of these things were developing, including, you could include Dr. Travell's work, and sure, she first was exposed to trigger points and and pain referral from Kellgren's work, I suppose. But she thoroughly developed the information that she published through her own research to validate what Kellgren said and also to expand upon it. And she certainly, I know that Dr. Sichan Gunn was aware of Dr. Travell's work.
Oh yeah.
So it's just fascinating to me. There was this moment in time in the mid 20th century where these doctors were using acupuncture and taking a much more, what do we want to say, like neuromuscular approach. And not that Dr. Travell was using acupuncture, but she was definitely aware of the use of injectate and things like that from neurotherapy,
Yeah.
and was doing, I think she was doing lidocaine, if not, just spray and release, but lidocaine injection. So,
Mhm.
but that all led to where we are today. And it seems like there's been this missing gap in the acupuncture education where we've all had to kind of learn this later, um, after acupuncture education. And then, like I said, don't always know where it came from.
Yeah, I mean, the history of this stuff's important. The histories of ideas are important. Yeah, there was a lot of stuff coming out. I mean, I think, after the Nixon visit to China, and then they saw like, people getting surgery with acupuncture, like all the pain management docs just went, there's like, okay, there's something else going on here. Pain works in a different way. It's not like just a wire from here to there. There's a lot more going on. So yeah, there was good research being done by Wall and Melzak's team, Melzak's team, and Pomerantz around fundamentals of pain, and then using acupuncture to understand pain and pain modulation in the body. So yeah, there's a lot the kind of a rich period for that. And, I mean, there's studies going back, I think Carol Levitt actually did one of the first that showed that a lot of the analgesic effect of acupuncture is the needle. It's like just there's a needle response. It's not the
Exactly.
It's not what you're putting in, it's whatnot.
Right.
He found that it was like how accurately you needled the painful structure.
Correct.
He did, he had 20 different areas in the body and had, significant results. And he was aware of acupuncture very much through the communist connection, being in at the then Czechoslovakia. They had good relations, or at least open trade relations with China and Russia. So there was, a lot of information going back and forth. So a lot of those Eastern European physical medicine doctors were well aware of acupuncture.
Carl Levitt, in his book, he's very, very pro acupuncture, and he was especially hoping that in the future, acupuncturists would take more of an anatomical approach, because he saw the successes on his own working that way, and using needles for scars and things like that. So
Yeah.
he was way ahead of his time. I think when he published that book, it might have been the 70s, when he was saying, oh, hopefully one day acupuncture will be the go-to for people who are having pain, and, especially if the acupuncturists are taking a neuroanatomical approach.
Yeah, I mean, he was, very much there needed to be like clear anatomical, neuroanatomical reason for what you were doing. He's a very wicked diagnostician, I'm told. My friend Susan studied with him for 20 years in Prague. And he was, he was a pretty active acupuncturist, actually. He's known for the manual stuff, but he was using acupuncture and, other techniques at his disposal as a physician. And he was definitely a proponent of acupuncture. I mean, like I said, he wrote kind of the seminal paper on the needle effect. You can look it up, I think 1979, Carl Levitt. It's out there. And it's pretty fascinating. And, really, I remember, reading those some of those reports and being like, oh my God, it's the needle. It's the needle. Like, they can't believe they let us get away with like the best tool of the whole thing. It's the needle.
Right. And he was very much against using any sort of injectate that would numb the sensations, because he really found the best result was when you could find the spot with the needle that was the most painful
Yeah.
and put a
That,
needle in it. And if the patient can't feel your needle, you can't find the right spot. He would look at their face and get feedback from their face or verbally that he had
yeah.
found the right spot.
Yeah. I'm Usher, right? You know,
Very much so.
it's the thing. Yeah. I think the conclusions, if I remember, it's been some years since I read that paper, but the conclusion was ultimately that the success of the treatment based on how accurately you were able to reproduce their pain,
Yes.
or you know that they went, ah, sure, yeah, that's it, you know.
Yep, that's it.
And so he found that there was a very direct correlation. So when you're needling at any level, dermatome, myotome, or sclerotome, you need to reproduce the type of pain that someone's doing. So like, for example, just using just bringing that back to like a periosteal treatment. If you're doing like cervical pillars, which I've talked about in a couple of videos that I've done. I think there's a lunch and learn on DAO that I did with Jamie Chavez that I talk about that. But you know, you're pecking the ligaments and the joint capsules of the cervical vertebra, and then it works best if you can get a dull referral, which is a sclerotomal type of pain. It's that kind of dull, hard, nagging, kind of hard. You're like, I can't, you know, when the patient kind of goes like, it's here somewhere, you know, and they can't flick all the muscles, you can't really reproduce their pain, the trigger point doesn't do it. That's often a sign that it's sclerotomal. And so when you peck at it, you actually want to try to get a referral like a trigger point. And so it works best if the referral will go to the area that is problematic. So like if someone's having shoulder pain and you're pecking, shoulders mostly C5, right? Most of the muscles, all of the you know, the joints, really C5, C6 is most of the shoulders, C4 for some of the skin. So, you know, you can go, okay, great. Someone has shoulder pain. I can peck at C4, 5, 6 at their articular pillars. But if you can get a referral while you're pecking at that periosteum down to the shoulder, especially even better to the area where it hurts, you can get some remarkable results. But that being said, that's not a limiting factor. So sometimes, like if I'm doing like an upper extremity scan, so I'm kind of running through, you know, deltoid strength, you know, rotator cuff strength, you know, serratus, the kind of standard kind of McMastery type of muscle scan. If I'm seeing like basically all the C5, C6 muscles shortening out and the serratus is relatively strong, I'm not going to think that it's shoulder stability that's the problem. I'm going to think that there's something happening at that level. And so then I'll go back and, you know, peck either unilaterally or bilaterally at C5, C6 area. And 9 out of 10 times you see all the strength come back and a lot of the triggers disappear. And then you can focus on, okay, that's the muscle that's causing the problem. You know, you can really just wipe out like all the lighter problems like in one go. And I find that often it's really helpful, you know. And that being said, you know, also the greater tubercle of the humerus is sclerotome C5, and there are dermatome, myotome, and sclerotome maps available online. They're pretty easy to find and free. I might be able to post a link if someone really wants to find them. And so you could conceivably just peck the periosteum of the greater tubercle of the humerus, right? So you can learn, you know, it's pretty easy to learn, like, okay, so that C5 is the greater tubercle, C4 is the clavicle, C5 is the greater tubercle of the humerus, C6 is the shaft of the humerus, C7 are the medial and the lateral epicondyles, etc. So, you know, you can then, if you learn where the sclerotome maps are, you can treat them either centrally or peripherally. And so that's a really handy piece. So sometimes when I just have a shoulder that I'm like, gosh, I cannot get more motion into this, or I cannot get these, the strength to come back on these muscles, no matter what I do, what's going on? And a lot of times pecking the sclerotome will get me that window that I can do either some type of manipulation, some different acupuncture, motor points, whatever. Because sometimes, you know, we all do it. You're like, I treated all the right muscles and it's still like, you know, wobbly all over the place and can't get the length back, even though theoretically you got that really nice contraction and maybe you left it on for a while. So an example of, a case I saw this week, I had a guy, shoulder pain. He's a little on the hypermobile side. He, he's like, I have shoulder pain. And then, he does the Apley back scratch test and is like, basically up to his, T3 or so. But he goes up to like T2, T1 on the other hand. So, that's why you check both. And it was his dominant arm that was restricted. And usually that one's more mobile. So anyway, I just treated the infraspinatus and teres minor motor points and then had them hooked to each other. And then I had C5 and C6 needled down to the periosteum, and I stimulated that at the same time. And we had 100% resolve of pain in 3 to 5 minutes of 2 hertz. So, it's that's kind of just an example of how you can just add it to something you're already doing, and it just takes a minute, to plop a couple more needles in. You can do it sclerotomally, you can think myotomally, you can think dermatomally. So if you're like, gosh, this person has this hand pain right over C6, and you can go up and treat C6. You can go and treat the shaft of the humerus. You can, you have options. And this also opens up some understanding of why like contralateral treating works, because there's it's called summation. So you can actually send more information to that segment if you treat kind of the same area or a similar dermatome, myotome, or sclerotome on the opposite side. You'll get stronger input into the cord at that level, at that segmental level. So that's pretty. I think that's a very healthy and healthy.
So when I'm already registered for your webinar, so I'm just curious. I wanted to make sure we weren't like having you give away everything before the webinar. In the webinar, can you tell me a little bit? Are you going to talk about some of the specifics of the pecking or the technique or the time and the settings and things like that? So we can try it ourselves.
Yeah, so I'm gonna, right now this is the overview of an overview. So
Which is still quite detailed, by the way. I mean, even if this is the abbreviated overview, it's still pretty informative, and we could probably take this and actually go to the clinic and do some stuff. So I'm excited to get even more detailed.
Yeah,
and
it's pretty simple to use. If you once you learn basically the 3 charts, well, you need 3 visual charts, and you need 3 just nerve lists of like innervation charts, and that's it. So yeah, I'll talk about that. So you need like dermatome, myotome, sclerotome charts. You need, and then you need you need to I guess really two innervations. You need to know like sensory muscular intervention, which are the same, and then you need to know autonomics. And so if you know that, and that you don't have to be like the liver is T5 through 9, peaking at T7 on the right, whereas the stomach is T5 through 9 on the left. You don't have to get to that level of detail because of that summation. It does allow a little, it actually is fine if you treat on both sides, because you're going to get a stronger input back to the cord on that level. So that stuff's really pretty exciting. So yeah, I'm going to cover this is an intro to an intro. So in the actual intro, I will go over the anatomy. I'll go over a little more of like what we're actually trying to achieve when we do this, and like how we can kind of improve our results. And then I'll also cover and I'll share some of my favorite techniques along these lines for like certain areas, just here and there. I will be teaching this class in person in San Jose, I think, it just depends, COVID willing, as we say these days. And I'm not sure if it's open to the general public or not. It's through 5 branches in their doctoral program. And then I'm in preliminary talks to take it to the East Coast in person. And that'd be a 3-day seminar where I would actually show how to do pecking and some like cutaneous nerve needling, and also some of the sort of shotgun techniques like pens, Craig pens, which I think is a really helpful. That thing's a workhorse in my practice. You know, whenever something's stuck, I'm just like, oh, I'll just try pens twice a week for 3 weeks, and usually that gets us to a point where we can start getting more specific and so on. So that is really powerful technique. If you're not familiar with Craig pens, well, maybe you are, because at least you saw the picture that I posted a couple days ago on Facebook. It's generated quite a bit of discussion. The Craig pens is basically, it's a shotgun segmental approach, so that your electrical acupuncture approach. So you're basically you're covering the sensory motor levels and the autonomic levels for the problem at hand. So like the cervical, just an example of a cervical one is like C2, C4, or C2, C6, T2, T4. You could add specific segments if you find them particularly tight along the way. You can do, traditionally it was taught on the bladder line. You could do it on the Huacho Jiaji. You can do it on the outer bladder line. You can angle inwards and get all 2 or 3 of those, you know, because that gets different branches. You know, the inner, you know, the Jiaji gets the medial dorsal branch, then the bladder line gets the lateral dorsal branch, and then the bladder meridian gets more the anterior branch, where it loops back, you know, comes back along here of the spinal nerves there. So you can, you know, that adds more stimulus to the same segment, so you get a much stronger effect the more of those branches you wrangle, if you will. So, you know, then you can add additional modules at different frequencies, electrical frequencies, to try to stimulate different neurotransmitters ultimately, or endorphins. That's the idea of the technique. It's really effective and it's really simple. And I don't know, Rich, you've been playing with it for a while, so since we talked about it first, you know, and I think you've had some really interesting experience.
I love using Craig pens for chronic pain, and I've been using it as a beginning 20 minutes for my migraine patients, and I really think it's great. It's just, I think anybody who lives with chronic pain is more sympathetic dominant. So just do some Craig pens just to calm them, and they often feel a little bit high from the treatment because of the endorphins, or the beta endorphin, or
Yeah.
you know, whatever other chemicals are you know, being created. But I'm really, that's my go-to for chronic pain that's just, you know, not budging as fast as I want it to. And I think it's a great beginning for those migraine people.
Yeah. Pens is great. Yeah, I mean, you know, you're doing the cervical pens. That's where all in the upper neck is where all the both sensory for a lot of the head, and you know, not the face, but the, you know, the hair zones. A lot of that comes from the upper cervicals, but you also have the autonomics and all the autonomic ganglia. You know, the upper, middle, and lower, aka stellate ganglia of the neck. So you can affect those indirectly through segmental acupuncture. So that's awesome. I love pens, and really worth exploring. I think that alone, just having that to add to whatever you're doing is worth it. And you can do it very simply, and you can add you really just have to learn 2 basic modules, and then palpate, and you can add or subtract needles as necessary. And then you do the motor points, or traditional points, or nerve junction points, or, you know, any of those things that you already know with that, and you can really enhance your results in the clinic. We were talking about what are we going to cover in the class. So yeah, I'll have some practical stuff. I mean, I want, you know, whenever I teach, I love ideas, but I'm a clinician. I'm not a scientist. I want ideas that I can use, right? You know, my grandmother's cousin was a physicist, a metallurgist, and he you know, he said behind every good physicist are 10 good engineers, you know. So, and I think that, you know, as clinicians, you know, like there's these few people who really do the research, and then it's like up to us to figure out how the heck to use it and what the utility is of that. So Bruce Pomerantz, Bill Craig was a researcher. He did some research on, and tests on, you know, their papers that you can find if you know where to look for old journal articles and stuff in the like American Medical Acupuncture Journal, Journal of American Medical Acupuncture. I can't remember what it is, what it's called, but they're in there, and they're interesting. You know, ironically, when I was writing my exit paper for my degree, I was doing all this research, and I found this thing called PINS, and I was like writing about it. My paper was on low back pain, and I just didn't know that it would become such a huge part of my life. It was just one of Bill Craig's articles showing how they were treating sciatica using pins, and I was like, well, here's some people doing acupuncture for pain, great. And like, you know, I had this paper, you know, long before I knew what a tool it would be and how useful it would be to me.
Pence for stubborn sciatica is like amazing.
Yeah.
Like, I know you're going to go into it, and I hope people will attend so that they can understand the different frequencies, the way Dr. Craig laid them out. It's very helpful and useful. The more stubborn it was, the more I think the different frequencies he would mix in, right? He would kind of start out at one level, and then if it's really stubborn, he would mix in other frequencies.
Yeah.
And I get a lot of good relief for sciatica patients, even when there is a real compression of the nerve. They
Yeah.
get days of pain-free
Yeah.
life, and they come back still feeling improved, even though they may still have, you know, some sciatica. So
Yeah.
it's really
I,
helpful for the stubborn stuff.
yeah. And it was really designed. He had a chronic pain practice. I don't know, Bill Craig, I think he saw like 10 or 11 patients an hour. You know, he had like a lot of assistants, but, and he, you know, basically just would, you know, treat people 3 times a week, 2, 3 times a week. And, you know, there was some research done. I don't think he did it, but this was just based on his stuff was all just based on, you know, the science of the day, which was these frequencies seem to release these endorphins. And then this amount of time, 20 minutes, the magical 20 minutes is when electrical acupuncture seems to peak. You know, there's not more effect after 20 minutes. And then, the treatment of 2 to 3 times a week was based on some studies showing how endorphin receptors and endorphin levels actually change over time. There's like plasticity in the nervous system really requires 2 to 3 times a week for that to happen. So there's Pence right there. You know, it was just, he looked at the science of the day and he said, look, and what he understood of, you know, musculoskeletal neuroanatomy, and went
Yeah.
with that.
Josh, we had some people chat. I think Kate was asking if we should in advance get some maps and charts ready for in advance of the webinar.
Yeah, I mean, I'll include some stuff in there, but you know, any pre-reading that you do would be
Is it
helpful.
is it pretty Googleable? I think some of this stuff you might even find on Pinterest.
Yeah, if you look up like sclerotome map, it's, you know, you'll find them. They're out there. They're not easy to find. You know, sclerotomes maps are not as easy to find. I mean, they're kind of like, it's weird unless you're in like a really specific, like a pain management zone. So like, I think the pictures I use in my thing are from like the New York Society of Pain Man. I can pull one up if you want. I'll show you guys real quick. I have a good one. Let's see. That is in this one. I'll share the screen real quick. Just give me a sec. There it is. And there's a link to where it came from. Okay, so you guys can probably see this one's from an article that was published by Springer. And so you can see how the sclerotomes go from, basically here's C4, C5, C6, C7, and they wrap around, but they are kind of like, they're kind of layered from top to bottom. They're in anterior to posterior. Same in the lower extremity. You can see where the twisting in the embryological development happened pretty clearly. Sometimes they pop around. They're kind of interesting. Stuff migrates quite a big distance. It's like, here's L2, here's also L2, that kind of thing. So, it's pretty fascinating stuff. And, it takes a little while to learn, all that stuff, but it's doable. It's not too hard. All right, let me stop that share.
Do you want to address Joseph Walker? He was saying nobody's blocking or conspiring against acupuncturists from attending the AAMA National Symposium to listen and learn from physician acupuncturists. And I'm interested in seeing that link. But I would just say we weren't talking really so much about now as we were talking about the past. Up to maybe the early 2000s, it was very difficult for us as acupuncturists to get any of the information that the Helms Institute was teaching to medical doctors. So yes, that's all changed. We're all benefiting from the fact that that's changed.
Yeah.
And I would just say that all, I think if anyone misunderstood what I was saying, all I was saying was, most of us have learned these things from acupuncturists and did not know where they originally came from.
Yeah. And at least in the early days, Helms has actively not wanted to work with LACs. In the American, I don't think he's that involved. He was one of the founding people, but I don't think he's that involved with the AAMA anymore. So there are plenty of physicians who are open and very, very friendly. So I don't want to make that a blanket statement. I'm just, his particular organization doesn't admit LACs in courses and so on. So
you can't learn IMS from C. Chan Guns Institute either, because they won't teach LACs.
Yeah.
To this day. And I had actually tried to get their manual. I just thought I would try to get their manual, and they said no.
Oh yeah.
Not
yeah, I mean, people have their territorial stuff. I mean, Gunn hated acupuncturists until later in his career, when he finally admitted that what he was doing was acupuncture, and acupuncture probably had something going on, but like, that was an evolution for him. He was like, I'm using needles, but in a scientific way, so I'm not doing acupuncture. Probably the origin of the whole like dry needling's not acupuncture debate, which I'm not going to open the lid on that fire right now.
He later wrote a very interesting essay about the benefits of traditional acupuncture, and that he felt that some micro trauma would expose the injured muscle to blood, just like a prolotherapy, platelet-rich, PRP type treatment, that it could be very beneficial as stem cells were exposed to the injured muscle. So he kind of changed his tune about acupuncture later. And my guess is he was just really trying to stay credible among his peers and didn't want to be seen as, alternative medicine, Dr. Gunn.
Yeah.
And but he did later, start saying that traditional acupuncture had its role and that there was some benefit.
Yeah. Yeah. And, I think you know, the older editions, the second editions of Travell mention acupuncture a lot. It was removed when the Dommerholt and the PT crew took over as dry needlers, took over the editing of the third edition. So I think Jamie Chavez did a search of how many times acupuncture was mentioned in the books, and it dropped like a lot. Yeah, and there's good studies on that stuff. Yeah, you know, yeah, you can. You know, you can attend all the medical acupuncture symposia and so forth, and you know, in Europe and so on. It's not necessarily as strict as here, but you know, there is sort of there's an information wall. So unless you have, like, I've been fortunate, I like the physiatrist next door is still an instructor in the Helms program, so I have access through him to being able to, whose name shall not be mentioned. You know, I have access to him through like kind of what they're talking about, what papers they're reading, who are they looking at, who's kind of the up and coming person. So that is kind of interest to me, mostly because, you know, it's a growing field, and you know, as acupuncturists, we're a really disparate group. We don't have very many people at universities and so on, you know, doing like research that are us. You know, I think Pony Chang. Okay, anyone else? Can you think of anyone else who's at a university doing actual like relevant research to us here in the United States or Canada? I don't think there's many. So we are a little bit at the mercy of the research being done by the physical therapists and medical doctors at this point. So we need to keep our eyes on kind of what's happening there, because that's where the research coming from. That's what's going to help us move our profession into the 21st century and beyond medicine, and where we really understand the mechanisms of disease and wellness based on segmental stuff being just one way to understand how things are organized, but useful. I just I don't want to sound like I'm resentful. I understand how every profession wants to protect what they have, but I'm also very interested in what that information is, if it's good. Because what, my experience, kind of first meeting physician acupuncturists, I got hired in this clinic to work there with them, and I worked with numerous Helms graduates. And, I was pretty blown away. They were getting as good or better results than I was getting with the acupuncture I was doing. So that made me sit up and take note, and has really led to kind of my ongoing study. I don't want conflict. I would think it would be best if we all got along, but there's still turf wars. That's
Can't
the
we all
nature
get
of this
along?
beast. Yeah,
I know.
Friends. So
well, Josh, I'm looking forward to your webinar. We're so lucky to have you as that intermediary between these great doctors and our field in acupuncture, and your years of experience. So I'm definitely looking forward to getting into a little bit more of the details, whatever you're able, what you can actually provide in a webinar.
Yeah. I'm going to write down the name. I'm looking really for it. I'm going to write down a name. I think it's called Segmental Anatomy by Wankura Klampik. I think I'm spelling this right. It's a translation of a German book. And it's really got a lot of interesting things that you can start. I mean, it's not a clinical book, but how it will help you to start to understand the different levels and how you can interface. The German physician acupuncturists are very into this segmental thing, and they do a lot of neural therapy as well as acupuncture. So there's a lot of bleed over. And so that's a great resource to start to really understand what it is you're actually stimulating and how you can start to apply it. Again, it's not a cookbook, but these kinds of concepts, the nice thing about segmental acupuncture is if you can read the chart and basically the pictures and the two charts, you pretty much have it covered. So are there any other questions before I sign off? I have another meeting here. I really want to thank you all for coming, and I hope to see you at the webinar at the CalAtmo website.
I posted it again in this event. If you went to this event on Facebook and clicked the link, if you go below, I posted it there. And then it's also, of course, in the Motor Point Acupuncture group in the feed as one of the announcements. So you should be able to find that.
Yeah.
We'll be posting the recording of this as we can. Josh is pretty busy today, but we'll try to get it up on Facebook in the next day or two if possible.
Yeah, and on the thread, feel free to shoot any questions or comments. I'm happy I'm available to talk to you all. And I do understand this is kind of it's a big shift of perspective. We just Rich has been doing an amazing job of getting us really as a profession starting to think of muscles, but then what's kind of above the what's kind of above the muscles, and all of that stuff is relevant. It's not that any one concept is better, but it's how can we start to get a gestalt view of what we're doing, and then you can start to understand wow, if I'm treating this muscle, why does treating this other muscle may help? And it's not just maybe they're synergists or whatnot. It's they share a similar innervation. So by treating a muscle that has biceps, also C5, C6, just like a lot of the shoulder. So that kind of stuff is kind of interesting to think about, how you can up your game. What if the shoulder's in a cast and you can't treat it? So you could treat the biceps, or you could treat or some other muscle that shares that innervation. The same segmental level. You can think about, gosh, I can help a person who has a fracture or an immobilized thing without having to directly treat it, and you can enhance your results and easily and pretty quickly. I mean, it's not. I think it's a low. The science of it is a high bar. The practical application is really quite simple, and I think you'll fly with it. So I want to thank you all for coming. It was really great to see you, and Rich, thanks for suggesting this yesterday when we were.
Yeah, I'm excited about it. I'm looking forward to it. So maybe we'll do another one after your webinar. We can discuss patients that we've been using segmental treatments on and something.
Yeah, and I'm really looking forward to the in-person courses. I mean, I miss seeing all
oh my God, I cannot.
That was a year ago, Rich.
It's so sad. I try not to think about it. It's just sad.
That was a year ago. The last time I saw you in person.
It's crazy.
Yeah. So anyway, I got a jet. It was great to see you.
All right. Thanks, Josh. Take care.